We are going to continue our pathology section, and today's topic is hypertension. So hypertension is defined as the persistent systolic BP of more than 130 mm Hg and or diastolic BP of more than 180 mm Hg. So the normal BP range is about 120 systolic and 80 diastolic. So any BP that is above 120 in systolic or 80 in diastolic is known as hypertension. The risk factors for hypertension include increase in age, obesity, diabetes mellitus, physical inactivity, high sodium diet, since we know that high sodium is responsible for conserving more water in the body. Therefore, high sodium diet can cause increased periload and hypertension. Then we have the excess alcohol intake, tobacco, smoking, family history, and the incidence is reported more in black than white population. The features of hypertension include the 90% of hypertension is known as primary or essential hypertension, and it is related to either increased cardiac output or increased total peripheral resistance. The remaining 10% of the cases are known as the secondary hypertension, and these are mostly due to renal or renovascular diseases such as hypermuscular dysplasia, which is characterized by the string of bead appearance the renal artery, and it is usually seen in adult females. You need to be aware of two terms which are hypertensive urgency and hypertensive emergency. So what is hypertensive urgency? Is basically it is BP more than 180 by 120, that is systolic blood pressure of greater than 180 and diastolic more than 120 mm of Hg, but no associated end organ damage, and if there is associated end organ damage, then this is known as hypertensive emergency. So what do we mean by end organ damage? Is basically encephalopathy, that is involvement of the brain. It can also be manifested in the form of stroke and retinal hemorrhages or exudative papillary edema. Then we can have myocardial infarction, heart failure, aortic dissection, kidney injury, eclampsia or nephrogenic hemolytic anemia. So the hypertension can predispose to coronary artery disease, left ventricular hypertension, heart failure, atrial fibrillation. The other less common manifestations include aortic dissection, aortic aneurysm. However, CKD remains to be one of the most common predisposition due to hypertension. Then we have the hyperlipidemia signs. These include xanthomas, tendinous xanthomas, and corneal arcus. So xanthomas are plaques or nodules composed of lipid-laden histiocytes in the skin. These are especially seen in the eyelids and known as xanthelasma. Then we have the tendinous xanthomas, which are lipid deposits in the tendons, especially in the Achilles tendon, that is in the posterior side of the leg, and the heel tendon, also known as heel tendon. Then we have the finger extensors. The corneal arcus is basically lipid deposits in the cornea, and it is also seen in elderly population commonly, also known as arcus senilis, but it can appear in early life if there is hypercholesterolemia. Then we have the arteriosclerosis. So the arteriosclerosis is of two types. One of them is the hyaline artery sclerosis and another one is the hyperplastic. So the hyaline arteriosclerosis is due to thickening of small vessel walls secondary to plasma protein leak into the endothelium, and this can result in essential hypertension or diabetes mellitus. Hyperplastic, on the other side, is the onion skin. It is in severe hypertension with proliferation of smooth muscle cells. Then we have the Mockenberg sclerosis, which is also known as medial calcific sclerosis. It is, however, an uncommon condition, and it mostly affects the medium-sized arteries. Calcification of the internal plastic lamina and media of the arteries can lead to vascular stiffening without obstruction. There is blistering appearance on the X-ray, which is a characteristic feature of Mockenberg sclerosis. It does not cause obstruction of the blood flow because the intima is not involved. Then the atherosclerosis, which is more common than the arteriosclerosis, it is the disease of gastric arteries and large and medium-sized muscular arteries. It is a form of atherosclerosis which is due to buildup of cholesterol plaques in the tunica intima. The location of atherosclerosis is most common in the abdominal aorta in the adult population, but it can also involve coronary artery and can predispose to angina. Then we have the popliteal artery, the carotid artery, the circle of Willis. The risk factors can be divided into two. One of them are the modifiable and another one are the non-modifiable. Modifiable risk factors include hypertension, tobacco smoking, or dyslipidemias. Non-modifiable include the age, male sex predisposition, post-menopausal status, and family history. The symptoms depends on the area involved. The most common symptoms are the angina, claudication, but it can be asymptomatic. The complications of the atherosclerosis include aneurysms, ischemia, infarcts, peripheral vascular disease, thrombus, and emboli. Then the aortic aneurysm. Aortic aneurysm is basically localized pathologic dilatation of the aorta, which may cause abdominal or back pain depending upon the location, and it is a sign of leaking, dissection, or imminent rupture. So the inguinal aortic aneurysm is usually due to atherosclerosis. The risk factors include the tobacco use, increasing age, male sex, family history. It can present as a palpable pulsatile abdominal mass. It is most often infrarenal. It is present distal to the origin of the artery. Then we have thoracic aortic aneurysm, which is associated with cystic medial degeneration. The risk factors include hypertension, bicuspid aortic valve, or connective tissue diseases. It is also seen in the Dutch syphilis. Then we have the traumatic aortic rupture, which is due to trauma or deceleration injuries such as car accidents. Most commonly at the aortic isthmus. Aortic isthmus is the proximal descending aorta just distal to the left subclavian artery origin. The extremity with widened mediastinum. So the widened mediastinum is again the characteristic finding of the traumatic aortic rupture. Aortic dissection is a longitudinal intimal tear forming a false lumen. It is associated with hypertension, bicuspid aortic valve, or inherited connective tissue disorders. It can present with tearing, sudden onset chest pain, radiating to the back, plus markedly unequal BP in the arms. There may be hypertension in one arm and the pressure may be reduced in the other arm. That is also known as radial delay. So the chest X-ray again shows mediastinal widening, and it can result in organ ischemia, aortic rupture, and infant death. So there are two types of aortic dissection. One of them is Stanford type A. Stanford type A is the proximal, that is, it involves ascending aorta. It can result in aortic regurgitation of cardiac tamponade, and the treatment is operative treatment. And the Stanford type B, also known as distal aortic dissection, it involves descending aorta, that is the below left subclavian artery, and the treatment can be beta blockers or vasodilators.